Hi, everybody. This is my last moment at the podium, so you know. I mean, I don't even have a podium anymore, okay? They've taken it away. Sorry. My name's Carol Dawson-Rose, and I'm your immediate past president of ANAC. Yay. And you are here at our final plenary, and we have an amazing plenary. So we're gonna start with that right away. I wanna thank everybody for being here. Been good? Been okay? Yeah. Okay, good, great. A couple of reminders or housekeeping, C&E reminder. There's a link on the app, and it'll also be sent via email next week. We're gonna turn this over in a minute to our amazing panel, and I wanna thank everybody for agreeing to do this. Is Chris Fox still here? No. So this is, the motivation for this panel is about how we talk to one another, even though we've come into work in the HIV epidemic at different points in the epidemic. And I called out Chris Fox because he was a colleague of mine at UCSF, and he and I had a couple of deep and meaningful conversations about how alienated he and some of his cohort felt by folks who'd been at ANAC around, because of what we've been through and how we talk about it and how we process it, and saying, like, we don't have that experience. We want to be here too. How do we be here, be more inclusive? So we had this ongoing conversation. And today, we have this esteemed panel that's brought together to talk from different points of nurses who entered HIV work at different points since the 1980s. We're gonna have our facilitator is Murray Penner, who's the Executive Director for Prevention Access and the U=U campaign. And I'm gonna turn it over to you, Murray, to take it away. Thank you.
Thank you so much, Carol. Wow, this is great. It's great being in person. I'm excited to listen to you all the perspectives that you have coming from your experiences, but I'm gonna start with a quick story about myself, and it's relevant, it'll make sense once I start with that. I just wanna say I'm really excited to be here. Thank you so much, Carol, for this invitation. It's exciting to be a part of this panel. So I was diagnosed with HIV on March 11th, 1986. And I remember that date so well because it was my dad's 50th birthday. That was when I got my official diagnosis. But I know that I was HIV positive before that because I had received a letter in the mail after I had taken a blood test for life insurance. And that letter told me that I was HIV positive. Now, thank God that we don't tell people they're HIV positive that way anymore. That was a really grueling time for me. I spent about 4 months not telling anyone about it, and it was a rough moment. I was in a lot of despair because, of course, in those days, we knew that you died, right? And that's all I could think about was that I was gonna die. So I held on to that secret, like I said, for about 4 months, and then I told my boyfriend at the time about it. And of course, the other thing I was really worried about was whether or not he was going to be HIV positive as well. And so we went and got tested together at the health department. And again, in those days, it was a 2 or 3 week wait. You had to wait for your results. You couldn't do the rapid test in those days. And when the counselor delivered my news, of course, I knew what my diagnosis was, but his was, he was HIV negative, which was amazing. The other thing that the counselor told me, he gave me a name of a doctor. I was living in Oklahoma City at the time, and he gave me the name of a doctor and said that I should call this doctor. Well, it took me another 6 months, despite my boyfriend at the time urging me to go to the doctor. It took me another 6 months to go to the doctor because I was just so petrified. I remember the first encounter that I had with the doctor's office. I called up, I wanted to make an appointment. The lady said, well, what are you coming in for? And I said, well, can I talk to, the doctor's nurse, because I just don't want to talk about it. And so the scheduler gave me to the nurse, Kristen, and Kristen was amazing. She prodded me and worked it out of me what I wanted to come in for, and she was so kind, she was so compassionate, and she was so understanding that at that point I knew I was going to be all right, at least, in the doctor's care. And so over the course of 8 years, as I saw Dr. Brown, Kristen, the nurse, became my rock. She really was my rock. The doctor had a support group for her patients because at the time in Oklahoma City, there was only one support group and it was limited as to who could get in. So she had her own support group for us, and Kristen was at every one of those support groups that we had in the evenings. And of course, at that time, my friends were passing away, people from the group were passing away. Kristen was at every funeral. I remember her coming to every single funeral of our friends. And the funniest moment I remember about Kristen, we had a lot of fun too, was she got pregnant, and we had a baby shower for her as one of our support groups. And all of us guys came to the support group in drag. It was the only time I've ever done drag. There is a picture, and I'm not showing it to you all, but my name was Rosemarie, and I had on this rose-colored dress and these white pearls, and that was fun. But it's the only time I've ever done drag, and probably the only time I ever will. Anyway, I tell you this story because I just want to say thank you to Kristen, and I want to say thank you to all of the Kristens that are taking care of people with HIV. It's really, really been a huge impact on my life. I also tell you that to kick off this discussion about how HIV care has changed over the years. I know that providing care today is really different than those early days, right? We've got PrEP. Thank God it's different, right? But we've got PrEP, we've got U equals U, we've got so many tools now that we can present to patients that we couldn't do before. I remember my doctor, when she first saw me, she said, well, I think what you should probably do is make sure you write a will, make sure you talk to your family, because I don't know how much longer you're gonna be with us. Thank God we don't have to say that to patients anymore. We're gonna have a conversation today up here for about 45 minutes amongst us, and we've got a few prepared questions that the panelists are going to respond to, and then we're gonna move into some questions and answers from you for about 15 minutes. This is gonna be an organic discussion. We're not really very scripted, so we're just gonna talk, and really looking forward to it. So with that, I'm gonna start our conversation. And we've got these three amazing human beings up here, these three amazing nurses who are going to give us their perspective. So I'm gonna ask each one of you, Candice Elam first, and then Bridgette Picou. Did I get it right?
Yes.
And then Bill Mannion, to tell us what your motivations were in terms of getting into nursing and really what motivates you to continue. So Candice, we'll start with you.
Okay, thank you for having me. I'm so excited to participate in this discussion. What motivated me to come into nursing, I took the scenic route. Nursing is a career change for me. I started out as a high school and middle school teacher. But I became curious about nursing with the birth of my first child. I had a midwife for the birth of both of my kids. I got sick with multiple sclerosis, and I lost my ability to walk. And the nursing care that I received at the time that I was diagnosed with MS, it was inspiring. It was so gentle and dignifying and kind. And I remember how good they were to me when I was facing what seemed to be the end of my future. And that kind of serves as a model of how I try to practice nursing. But with those setbacks, the babies, the MS, I even had postpartum depression. It took me 8 years to finish a community college nursing program. So I started out with my associates in nursing. I got my online BSN, and I just finished my DNP in May. And then coming into HIV care, I was working in Newark, New Jersey in the emergency department. We had I had hardly any education about HIV from nursing school. I mean, what is it, maybe like a 1, 2.5, 3-hour lecture. And here we are in the emergency department taking care of lots of patients who are either being newly diagnosed or people who are out of HIV care. I knew nothing about the HIV care continuum. I knew nothing about, HIV treatments and such. And at Rutgers, we used to have an HIV nurse practitioner certification. And so in order to bring myself up to speed so that I can take better care of those patients, I enrolled in that program, and I'm the last to graduate from that program. Unfortunately, the program is no longer funded. But yeah, that was my long and winding road into nursing and then into HIV care.
And so you've been in HIV care for how long?
I would say like 6.5, 7 years.
Okay.
Yeah.
All right.
Yeah.
Okay. Bridgette, let's hear from you.
So, full disclosure, sometimes when I get passionate or emotional, I cuss or cry. Don't blame my mom.
That's
She
all
raised
right.
me right, okay? So, my name is Bridgette. I am I'm a nurse in Palm Springs right now. I became a nurse because I needed a career change. I had been in customer service practically my whole life. My mother worked for the phone company. My brother worked for the phone company. I worked for the phone company. And the phone company was going to be the place that I retired from, right? Because it was a good job. It wasn't. So at the time, I was out of work. I was on disability. And I went to the doctor because I had a sore throat. And the doctor said, oh, it's probably just strep. Here's some antibiotics. Go home. But fortunately for me, at the time that I was there was a program that was they were trying to lift it off the ground for women's health. And they offered me a free PAP. And I said, okay, I'll do it. And that is when I found out that I was HIV positive, was from that just kind of happenstance. And I almost didn't go back for the results for that test. And so all of this stuff coalesced into this place where I needed to do something different with my life. I still wanted to deal with people because I enjoyed that part of my career, but I didn't want to do customer service anymore, right? I don't like people like that. So the government at the time was offering a retraining program for veterans over 35. I was 40. And it had to be in a career that was going to grow, that was going to be in demand in order for them to pay for it. And when I was a little girl, I wanted to be a nurse. And it never panned out because life does what it does. And so when this opportunity came up, I decided to take advantage of it. I went to nursing school. I went to the trade school, the vocational school in my area, got my LVN, and I was determined that I was going to be a hospice nurse because my father was ill for a long time, and his hospice nurses were the most amazing people I'd ever met in my life. And my thought was, if I can do that for one family, what they did for me, then I would be good to go. And long story made shorter, the AIDS service organization that I was going to get my care for my HIV, the therapist that I was seeing there said, hey, Bridgette, why don't you come work for us? You should work here. I was like, I'm not doing that. I'm gonna be a hospice nurse. That's what I wanna do. And I went to a women's group that they had, and talking to the women in that group who were ashamed, who were stuck in fear, who had been living with HIV for 10 years, for 18 years, for 12 years, who had family members they still hadn't told that they were positive, was devastating to me because nobody should live in that kind of fear, right? I was scared. I was still terrified. I was still trying to deal with this diagnosis that was changing my life, but I knew that that wasn't the life that I wanted to live, and I don't want anybody else to live that life. So the second time he asked me if I wanted to come and work for him, I said absolutely. And so that's how I'm here.
Okay, Bill, I'm not going to say how long you've been doing this, but you've been doing it for a while, right?
A couple years.
So take it away.
I was never a little girl. I never dreamed of growing up to be a nurse. No. So when I went to college, I drifted through 4 different majors and couldn't figure out what I wanted to be when I grew up. And a friend of mine, I was looking for a job for the summer to pay for school for the next year. And a friend of mine was a nurse, and she said, come work at the nursing home with me. If you work the night shift, they give you extra pay. Well, that was enough for me to get there. And so I worked at this nursing home all summer, and I loved it. And it was the first job I ever had where I really loved what I was doing. And so then I went to nursing school. I went to Rush in Chicago. And I was there at a time, Luther Chrisman was the dean. And at the time, there were very few men in nursing. There were about 4% of nurses were male at the time. But I was at a school where the dean was a man, and he looked for men, and he, like, once you were a student there, he kind of took you under his wing and kept you going in the right direction and stuff like that. So I went to Rush, and I graduated in 1981, and I was working in spinal cord intensive care, which in retrospect was a really easy job compared to what I ended up doing later, but at the time was a very difficult job, working with very young men, mostly men who have spinal cord injuries and are paralyzed or quadriplegic. And then in June of 1983, a friend of mine from college, who was my next door neighbor, was diagnosed with AIDS, and he was the 31st person in the state of Illinois to have AIDS, my friend Randy. And so I started to volunteer. I went to Howard Brown, which at the time was a gay STD clinic in Chicago, and I knew they had a little AIDS project, and I went to the one staff member, and I offered to volunteer, and she said, what do you do? And I said, I was a nurse, and she said, oh, good, we have these hospitals that need talks. And I'm like, I don't know anything about this, and I'm petrified of talking. And she handed me a flyer, and she said, well, we got this flyer from a talk in New York, use this. And the first talk was horrible, and the second talk, I realized that, like, I connected with people, and people were listening, and people were learning something, and that kind of took me off. Within 6 months, I had written a grant, and I was the first AIDS education director at Howard Brown, and I did a lot of prevention education in the gay community, and then I did work educating healthcare professionals throughout the state of Illinois. Started the State of Illinois AIDS hotline with a friend of mine, so we did all that. And by '86, I had moved to Los Angeles, and I started managing inpatient AIDS units in '86. And at that time, basically, people were extremely sick, and people were dying. And it was hard. It was very, very hard. I had a great staff, and people really cared, but it was horrible, horrible work. And at the same time, in many ways, it was also exciting work. I mean, there were all these new diseases that they actually weren't new diseases, but very rare diseases that suddenly were having treatments discovered for them. And so there was constantly something new to learn. And we were making a huge difference for our patients, but ultimately the patients were dying. So I found it very challenging. And then in '87, I was invited to a meeting with a number of other people, and we founded the Association of Nurses in AIDS Care. Which two things about that, and those of you that have been around have heard me say this before. At that first meeting, we set certain goals. We wanted a national conference, we wanted local chapters, we wanted continuing education, we wanted certification, and we wanted very specifically a peer-reviewed journal. So all of that happened, I believe within 5 years, but it happened relatively quickly that all of that happened. And the great thing for me was that then I found support from nurses. I had support from other people that worked in HIV, but specifically nurses that understood what I was doing, and one of them is here, another co-founder, Allison Moed. So suddenly there were people to talk to and to learn from, and I'll never forget, Allison called me up shortly after we had that first meeting, And she called me up and asked for advice, and I was like, well, you can't ask me for advice. You're at San Francisco General, and you've been on national television, and I don't know anything. And she's like, I'm just about a step ahead of you. And, and from that, learning, we're all looking, and we're all trying to find information. So I ran AIDS units from 1986 until 1998. At the peak of the epidemic, I had a 40-bed inpatient unit plus an outpatient center. And we ran an average daily census of 42. And in 96, once combination therapy came out, we went from having an average of 42 patients a day to an average of 5 patients within 6 months. And the epidemic just completely changed in the United States, particularly for people who were insured. It took much longer for other individuals, but it completely changed because suddenly there was treatment. And before that, we were just chasing opportunistic infections. And if you could treat one opportunistic infection, there were going to be 4 others behind it. And it was just trying to keep people alive as long as we could. So,
Wow.
that's my story.
Well, let's give them all a round of applause for sure. Such experience, such passion. Thank you for what you do. By the way, you can look at their bios on the app. We didn't go through any of the bios. We didn't want to take the time to read those, so their bios are on the app. So let's switch gears real quick to COVID-19, get that out of the way, and then we'll get back to some conversations about then and now and some other motivating factors. So we know that COVID-19 is, layered on a whole host of now issues that we have to deal with for people living with HIV, and of course others as well. But Bridgette, how would you describe the parallels between HIV and COVID and the differences? Because there certainly are some of those as well.
I think for me, like what I learned very early on when the lockdowns started happening and people were getting really, really scared. And our clinic was able to pivot fairly quickly into doing telehealth. But the consistent theme that I was hearing from my patient, and my patient population tends to be older and people that have been living with HIV for a long period of time, was that they were scared. They were feeling the same kind of isolation that they were feeling in the beginning of the pandemic. And I wasn't there, and I can't imagine what that must have felt like, but I definitely could feel the anguish that they were feeling in regards to that. And so it very much became, how do we stay connected, right? Like, how do we continue to be with each other when we can't be with each other, which is, HIV isolation is a real thing, and I think that it is one of the main drivers that make people give up and that make people feel like they can't go on. And so that parallel it was a little bit frightening. And as far as differences, I think that, and it's a shame, because what I noticed is that all of a sudden nurses, not all of a sudden, we've always kind of been heroes, but nurses were heroes. And I guess what I'm saying is that for the world to kind of come together with COVID and, we're gonna fight and we're gonna stand together and we're gonna get through this, it was directly opposite of what happened during the beginning of the HIV pandemic, or epidemic, I'm sorry. And it should have been exactly the same thing. It should have been exactly the same thing. We wouldn't be where we are with stigma and shame if the world had done the same thing with HIV that they did with COVID-19.
Yeah, we're going to come back and talk about shame and stigma too in a little bit in terms of HIV care, but thank you for that. Candice, what are your perspectives on the differences and the parallels?
I mean, what's very similar is the misinformation, and how prevalent it is and how misinformation fosters hatred and kind of keeps people at each other's throats. My my professional interest is in HIV screening. That's what I did my doctoral project on. Specifically, emergency nurses performing HIV screening. And when I spoke with my colleagues, we were, at a hospital that had a policy that supported HIV screening in our emergency department, routine HIV screening. And I noticed that at least half of them were not getting done. Half of the eligible patients were not getting HIV screening. And I would just have these informal conversations with colleagues to find out why that is. And a lot of it had to do with this, mistaken belief that, and this is what one individual was very adamant about. We're in the city of Newark. I'm not testing our patients for HIV. This is just another way to stigmatize the Black and brown people who live here. And I had a very long conversation with her, saying that HIV stigma is one thing, but you don't address HIV stigma by not testing. And what's similar about HIV, and by the way, this conversation took place within the past 5 years, so this is not a long time ago. For me, the thing that is similar with COVID and with HIV is that not understanding how to prevent this disease is fostering stigma, fostering hatred, and is very pro-virus. It allows for the virus to spread completely unchecked.
For sure. Yep. Thank you. Bill, you described already some of the early days of what you were seeing, but what are your perspectives on this?
So I think two things. One actually was talked about quite well earlier by Dr. Grant when he was speaking, which is mental health. And I think the early years, the mental health challenges in the early years of HIV, in many ways are very similar to the challenges that nurses are feeling today, of many times just feeling powerless over the ability to help your patients because of just everything that's going on. And kind of the caution I would have about that is post-traumatic stress. And we talked about it in the 80s and in the early 90s, but few people made time to do anything about it. And in retrospect, we really should have done a lot more about it because it plays out a lot in people's lives.
It sure does. I was in the aging session earlier, and there was a lot of talk about the PTSD, and having lived through that period, there is some PTSD with that. But there's PTSD from lots of issues as well. It's
Right.
not just people dying. There's lots of PTSD that I think people with HIV are facing. So
I think the other thing that is similar, although not to the same extent, is the impact on local communities. And so because COVID is a transmissible disease, you see it happening in local communities, and you see whole families getting infected and multiple people in a family dying. And that's very similar, but it's not quite what happened to the gay community in the 80s. And it's very hard being in the gay community today to kind of think about what it was like in the 80s. Many people were not out to their family. Most people were not out at work. You could lose your job, you could lose your home, you could lose all kinds of things if people knew you were gay. So it was a very different thing. And so the community, we tended to live in gay ghettos where kind of everybody was in one neighborhood. And so then when HIV came along, just the way that it sliced through those neighborhoods and these close-knit communities of men was very, very specific in a way that's much more than what's going on in COVID. But there is a similarity, because if you're in one of those families that's been dramatically impacted by COVID, you're going through that same kind of hell.
absolutely, absolutely. So I'm going to turn now to your reflections of your earliest days working with HIV patients in your roles. And I'd like you to tell us what you would tell your earlier self based on where you are today. So, what would you say to Bill, what would you say to your younger self when you were just getting into nursing now that you wouldn't have known then?
A couple things. I would let myself know that I could do this. because I was often very unsure of what I was doing. And that was a horrible, particularly when I was a manager, to be managing a staff and the patients were mostly people I knew. To be doing that and be uncertain was a horrible feeling. And to know you have the skill set and you can do this and you can do this well would have been very helpful. So I think that's one thing. I think the other thing is the idea that I would come out the other side of it. There was so much uncertainty. There was so much focus on live for today. And I didn't realize until much later how much I took that to heart. Actually, after 96, when treatment came out and suddenly there wasn't a need for inpatient nursing units for HIV, I was kind of lost and I didn't really know what to do, and I saw a career counselor. And the very first time we met, she asked me, she said, well, you're about to turn 40, which at the time I was horrified. I'm about to turn 64, so now 40 looks really good. But she said, you know, turning 40 is a common time for thinking about careers. Where did you think when you would be when you turned 40? And without even thinking, I just said, well, I didn't expect to be here. I thought I would be dead by now. And she said, but you never planned for your future. And I'm like, no, I just kept doing whatever was in front of me every day. And I didn't look for jobs. I didn't apply for jobs. I just kept doing what needed to be done, and people would come to me and offer me a job. But it was all just getting through. It was just this constant getting through, and I didn't envision a future. I didn't plan for a future, and it would have helped to know that that actually was going to be there.
For sure.
But for many people, it wasn't, and I mean, there's no way. You just don't know.
Yeah. So what has over the time period? What has kept you in it then? If you didn't know that you would end up on the other side, at least in the early days, what kept you in it?
I've done a lot of different things. So when I left hospital nursing, I went to work in the pharmaceutical industry, originally in the United States. And then I started working in philanthropy in the pharmaceutical industry internationally. And then I worked in medical affairs internationally. Now I'm a consultant to a pharmaceutical company. So I've always found kind of different roles. And in volunteer work, I've found different roles that I could do. And so there's always like something I can offer. And that has meaning for me, is just, what can you do?
Got it. Okay. Candice, you're obviously, a lot newer to this in terms of entering the field. What would you tell your first, yourself in those first days of your HIV care?
My first days of HIV care, I was really overwhelmed by how little I knew and how ill-prepared I was. I had some patients who were taking Truvada, and HIV was listed as one of their diagnoses because somebody just saw that on their medication list. And, that's an HIV drug. That drug is for HIV, therefore that person has HIV. So there was no information in my emergency department about PrEP. That person was taking PrEP, was HIV negative. There were other patients who were out of HIV care for a very long time. I had this one woman who came in, let's say it was June, and she had PCP pneumonia, and then she came back by the beginning of July, and she now had iris from having, had a little bit of art, in those few weeks. So that was terrifying for me, because I knew that what I was looking at and what I was dealing with was, poorly managed HIV as well as HIV stigma. And my advice to my earlier self is read and find people to mentor you, to coach you, to teach you how to advocate for your patients. I wasn't in a setting where that was available to me. And fortunately, I was at Rutgers in a program that had heavy HIV education for nurses. And so I had that resource, but my colleagues didn't. Our leadership was not providing that, and asking most, acute care nurses, they're not getting any continuing education on HIV. So, find people who can help you to be good to your patients.
Fantastic, yeah.
Thanks.
Bridgette, you've been in HIV nursing now, is it about 7, 8 years?
Yeah.
What about you? What would you say to your earlier self?
To say more. You know that expression, if you see something, say something? To say more, right? Because, like I said in the beginning, when I first started nursing, I was still fairly new in my diagnosis. And I'm not a person, I don't typically wear my status on my sleeve. I don't wear a t-shirt. I don't shout it at everybody that I see. And I think in retrospect, I probably should have a little bit more. There have been a number of times when I've had women tell me, well, I didn't think I could be a nurse. I didn't think I could be in healthcare because I have this infection, right? I'm really big on language, and I try to teach people, no matter how long you've been doing this, and old school people that have been doing it for a long time, it's not out of any sense of you should know better, because you don't. Like, old school doctors still say infected. They still tell patients you're a victim of HIV. Or people who aren't in it use words that stigmatize us without realizing that they're stigmatizing us. And so my advice to myself would be, if you see something, say something, and say it louder. It's not that I don't correct people, but I don't always shout it like I should. And this, like being here amongst this group of people who are in it and who care about it and who are in it because they want to be in it, and shared experiences and shared pain, shared joy, shared success makes me want to shout it more. So that would be it.
Awesome. So that's a great segue. You set it up perfectly. We didn't even plan that, but obviously we have an opportunity. We all have an opportunity to change the narrative about HIV. Stigma is so pervasive still, and it shouldn't be, but it is. We all know this, and we have amazing tools. Again, we have PrEP, we have U=U, we have all of these tools that can keep people undetectable and they don't transmit to their sexual partners. We have tools to keep people HIV negative and safe. So we can change that narrative about people living with HIV being vectors of disease, right? How do you implement that into your work? How do you work to combat stigma, shame, fear with your patients? And Candice, I'll start with you.
I had a patient while I was in NP school who had been diagnosed with HIV for about 2 years. And he had come off of his medications because he felt like he, just deserved to wither away. And he would never get married again, and he hadn't told his parents and such. And he was kind of punishing himself for his diagnosis. And he was never told about being undetectable and U=U. So impressing upon him that, when you're undetectable, you're not going to transmit this to somebody that you love. And, the fact that you have a chronic disease doesn't make you unlovable, doesn't make you undeserving, but just it took a few tries to get him to believe me when I told him about U=U. And that stood out to me because I thought about all of the other people who, as healthcare providers, we think they know what we know because we may have said it in one way or said it in another way, but people have to hear it in different ways. And the first time you say it or the 12th time you say it, they might not fully get what you're telling them. I mean, me having been a patient with, newly diagnosed with multiple sclerosis, I understand that when you are faced with a diagnosis and medication choices, you don't necessarily, your ability to reason through what's being offered to you is really diminished from fear and anxiety over, well, will I still be able to work, and will I get better, and what about my kids, and, How will I pay for this? And what about the medication? So our patients who are living with HIV or with anything, whether hypertension, right? Patient teaching has to come in the way that they can accept it as often as you can give it, in order to provide them with the information that they need to be better, to do better, to thrive in spite of their condition.
Yeah, I couldn't agree with you more about the importance of the repetitive messaging, because people don't always hear. When you tell them one thing, they hear something, and it may not be
What you intended.
What you intended, right? So, Bridgette, you've talked about your lived experience with this, but also in your work. How do you incorporate your messages, and how do you work with your patients to combat that HIV stigma?
I really try to remind them that they're not alone. They think they are, but they're not. I try to remind them, like I was saying, I'm big on language, and so when a patient comes to me, especially a newly diagnosed patient, and says, well, when I first got sick, or when I found out I was infected, and I always correct them immediately. You're not sick. You're living with something. You're not infected. You're living with something. You have to change the dialogue and change the tone with people, because even to say that, I try not to say you're living with the chronic disease. I try to say you're living a new life process, right? It is, and I hear people that have been positive for a long time say it too. It's life before HIV and life after HIV. And so it's what you are gonna make it be. And so when I'm talking to patients and to people about HIV, my goal is to normalize it. I'm still a normal person. I'm still cute. I'm still,
Yes, you
right?
are.
So, and, if I have to say so, at 49, I'm still kind of hot, but. Woo! So the idea is to normalize it. The more I can convince them that they are normal and they're living a new life process, the less likely they are to walk around with their head down and be shameful about what's going on.
Fantastic. Thank you. Bill?
So I don't work with patients these days, but I work with, so I do consulting work for a pharmaceutical company that works with patients and doctors and nurse practitioners and the like. And it's amazing how often people say things that are just kind of beyond. And so I have to speak up often. And particularly as the epidemic has shifted and more it's people of color and more it's poverty, people are very comfortable in their wealth and in their whiteness and say things that are very inappropriate. And they don't even think about it because that's just the way we talk in our communities. And it's, it's those people, it's not these people kind of thing. And so I speak up, and one of the things is, so I've been positive for 31 years. And for a long time, I never talked about it in an employment capacity because I had some pretty significant roles at the pharmaceutical company I worked for, and it was clear that that wasn't going to continue if they knew I was positive, just the things they said. I mean, like, I wrote their AIDS in the workplace policy, and the other people on the committee, just frightening things came out of their mouths while they were developing a policy for the benefit of people with HIV that were their employees. But so then I started the work I do now. I started telling people I was positive, and then when they say things, I just question, and frequently people say things, and I'm like, well, what do you mean, like those people? And they'll say more, take themselves further down that road, and I'm like, well, that's me for 31 years. So would you like to expound on that a little more? And then I just get in their face, and I'm just kind of like, how did you, where did you go, and what do you think about that? And it's interesting, I mean, also in the gay community, and particularly in the 50-plus gay community, there's a lot of stigma that was formed in the 80s and in the early 90s that is still there. And particularly the HIV negative gay men are very comfortable in that. And so they're willing to say things that are just, again, ill-informed and inappropriate in many ways. And so even in our own community, I just find the need to keep talking to people and bring that up. And it's like, come on, you know better than that.
Yeah. Bridgette, I want to ask you a question about older people living with HIV. You're in Palm Springs. Clearly there's an older community there. Talk a little bit about that, and you know, I think there's clearly a lot of long-term survivors there who have been in this epidemic since the beginning. Mm-hmm. How do you, as a young hot woman, you said it, I agree. How do you bridge that gap? You didn't live through that, the early days of that. Well, you lived through it maybe, but you weren't involved in it. How do you bridge that gap?
So actually, I have a story about that. Tez was saying earlier that old gay men that have been living with HIV for a long time are a crotchety group. Yes, y'all are. Absolutely. And so one of my patients who always came in pissed off at the world, angry at everybody, and my thing is to be very consistent in my behavior, right? Like, I'm gonna be the same person every time you see me. And I lower my tone, and we're very calm, but I'm also very straightforward. So he came in one day, and he was angry about a prescription, and fussing and cussing, and I said, okay, so why are you so angry? And he said, you don't know my life, and you would never understand what it's like to be HIV positive. Boo boo. Hello. And that was the click, right? Like, that's how you bridge the gap. There is always, whether it's HIV, whether it's our favorite color, whether it's the music we listen to, the music we hate, there's always a common thing with anybody. And so I think it's important for people who have been living with HIV for a long time and who lived through the early epidemic and who had friends that died and who lost loved ones to understand that that was a thing and it was real and it mattered. But because this 20-year-old now has HIV and has a choice of one medicine, one pill once a day, doesn't mean there's not a monster under his bed, right? So it is finding the commonality and understanding that you have a right to feel the way that you feel. I have a right to feel the way that I feel, and we can find someplace right in the middle.
So that's amazing. I completely agree. And I guess the other thing I want to explore a little bit, maybe let's start with Candice. You've got young people coming in that don't know the history about HIV. What do you feel the level of importance is to let them understand the benefits that they have, the tools that they have now to either stay healthy as a negative person or, stay healthy as an HIV positive person? How important is that past to them?
It's extremely important for them to know, what has taken place over time. I think what young people today are facing is a complete lack of coherent, comprehensive sexual health education in public schools.
Yep.
This has gone on for, I grew up in Catholic school, so I wasn't going to get sexual health education in school. My kids go to an Islamic school. They're not going to get comprehensive sexual health education in school. But similarly, throughout the country, there are other children who are going to public schools who are getting abstinence-only education. And then when they go to their pediatric provider or their family practice provider, their parent is in the room, and you can't ask, you can ask those questions, but you may not get the actual answers. So as healthcare providers, we're also limited in the extent to which we can provide them with sexual health education in that once-a-year well visit that we get with our adolescent patients. So it's extremely important for them to know the history, but it's not necessarily their responsibility to go seek that history. You know, we as healthcare providers need to be advocating for better sexual health education in schools. I came of age in the 90s when MTV had all of this information about sexual health education and safer sex and condoms. And they had this years-long campaign about knowing your HIV status. I don't think adolescents have the same thing or anything similar today. So, you know, there are lots of things that those of us who grew up in a time where we had better education, we can bring that education to them. We're just not really doing it.
I couldn't agree with you more that I think it's important that they understand that there is a history,
Right.
but you know, things are different today, and we don't want to spend our time, our precious time that we have with patients or people we are working with, going over the history. It's important that they know when there's so much that they need to know now
Right.
about keeping themselves safe or healthy, et cetera. So, Bill, do you have any thoughts about the...
So when you asked that, I started thinking about my father and my uncles. So my dad and almost all my uncles were in World War II. And my father never talked about it, but a number of my uncles talked about it, and certainly other older men, you know, when I was growing up, were talking about it because they had all been through it. And it was a nightmare. I mean, my father was in D-Day, he was in the Battle of the Bulge, never once spoke of it, but my uncles spoke about it. And I was always kind of like, yeah, whatever. Because it wasn't my world and it didn't mean anything to me. It means a lot to me now that I'm older and I understand what they went through. But when I was a kid, it didn't really mean anything. And I think the history isn't important unless you relate it to where you are today and what it is today that's important about that. I mean, I could go on for hours about the 26 diseases that fit the AIDS criterion and all the various treatments, none of which is really important unless you happen to have somebody with aspergillosis and you need to figure out how to treat it. But otherwise, why waste people's time going through all of that? But what people do need to understand is this is a serious disease. You can get this. If you get it, you can live with it, but you can also prevent it, and there are ways to do that today. They don't need to know the whole history of how we got to the ways to prevent it today, but they need to understand prevention's available today.
Absolutely. So we're getting close to time to get some questions from the audience, but I want to let each one of you give some final thoughts about just how generations of nurses can work together and how you can be that person that you can learn from, the person to seek out, how you can be that for each other. So, Bridgette, I'll start with you.
I just want to, real briefly, I kind of disagree with people not knowing the history because I think that we'll never get a place to normalization. We'll never get to a place of normalization. We'll never get to a place of understanding if people don't understand what happened, right? If they don't know why calling it GRID was a bad idea, they will continue to think that it's a gay man's disease and not a human disease and not a human condition. So I think there does need to be a way for us to kind of bridge that. Like, I made it a point to watch movies, like, and the band played on. Mm-hmm. The 5B movie was so inspiring to me, right? And I think that people need to see that kind of thing so that they can make the connection, because if you don't understand something, you don't care about it. It's just like, that's one of my frustrations about HIV care and primary care. Primary care physicians don't care about HIV because they know they can send you to an HIV specialist, but primary care physicians are in a position to be able to catch HIV for someone who doesn't come to the doctor regularly, so she doesn't find out when she's getting a pap smear. Does that make sense? So I think that matters. But And I'm sorry, I forgot the other question because I was on a tangent.
Just any concluding thoughts, and maybe that was your concluding thought.
That can be my concluding
Okay,
thought.
fantastic. Bill, concluding thoughts?
No, go to questions.
Candice?
I don't have one.
Can you hit me with that question one more time?
Just if you have any final thoughts about, how you can be supportive for each other throughout the, intergenerational support, I guess.
Right. I mean, I have to tell you, I've been a beneficiary of intergenerational support as a nurse and in HIV care specifically. My nursing angel is sitting over there in the back. And
Raise your hand, Angel.
so what I can say about Dr. Ray is that, she saw my curiosity, she nurtured my curiosity, she gave me the space to kind of explore my ideas, and she gave me the support and the confidence to just keep going. I did not find that at work. I found that in school. So I guess in your workplaces, find that young new nurse with lots of energy and lots of curiosity and attitude and opinions, and just, love them and be kind to them. And encourage that energy and try to direct it to something meaningful.
I love that about nurses, how kind you are, how compassionate you are. It's amazing. And I've heard this quite a bit. I haven't been at a lot of sessions, but how the doctors are the ones that walk in and, boom, 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 and it's the nurses who provide that compassion. So my hat is off to all of you. I think we should all give each other a round of applause for all of that. Okay, we've got about 15 minutes for questions from you all. There's microphones. Please keep your questions as brief as you can so that our panelists have an opportunity to provide brief answers so we can get as many thoughts out there as possible. Take it away.
Hi, I'm Michelle Crespo-Fierro, or Dr. Michelle Crespo-Fierro, from New York City, and I want to make a couple of comments. One is, first of all, thank you so much for doing this. I think it's so important that we continue to have these dialogues about our history. Bridgette, I am so on it with you, but not so much, not only with our patients and the populations at risk, but also with the nurses that are here. So those of us who are, and I'm kind of like in the middle, okay. But I wasn't one of the founders, okay? But I've been around a long time, but when I work with students, and when they don't understand what happened in the beginning, and about how, exactly as you said, this was allowed to get where it got to now. Why? Because people wanted to say it was them, it's not me, it's not. So I think that that's really important. I think that our new students coming in, our new nurses need to know that history, the stigma, some of the trauma that we dealt with because of what was going on, and how we saw people not being cared for and how terrible that was. I think that needs to be shared. So that way we could potentially not allow this to happen again. So that's one.
Can I say something to that real
Yes,
quick? Just
please,
before you-
please, go ahead.
I think that one of the main ways to address that is by having more than a few hours of lecture or a day and a half of HIV training in nursing school.
Absolutely.
That has to change. There's over 1 billion people living with HIV worldwide. Why is there not the same care and dedication given to HIV education that there is to hypertension or diabetes? And now I'm about to cuss, but go ahead.
No, that's okay. And let me tell you, what I do, every single one of my students knows about HIV. And in some way, shape, or form, because I can't teach without talking about HIV. I just can't do it. I can't teach without talking about SDHs and all of that stuff. So that's just part of who I am. But I think it's super important that we do that. The other thing I wanted to say, and this is to Candice? Okay. We need to continue to push for safer sex education and healthy behaviors in all schools, all throughout their time in school, no matter what. Even our religious schools need that.
Absolutely.
I am so happy that
Absolutely.
I am blessed to be able to provide to Catholic independent schools in New York City. I provide safer sex education, STIs, safe, healthy behaviors, relationships, but we've got to put ourselves out there so we can get in there. There are lots of schools. Maybe it's not blasted, but they're getting us in. So we just need to be ready to step through that door. And that's all I wanted to share. But thank you so much for being here. I'm so glad.
Thank you.
Thank you, Dr. Crespo-Fiero. I totally agree with you about, targeting our religious schools. There is a nurse practitioner, also an ANAC member, also a Rutgers graduate, from the DNP program. Her name is Shakira Abdurazak, and she does a nationwide program of providing sexual health education in mosques to adolescents. So I think she's gone online and she's been doing it remotely, but yeah, there are people, within my religious community that are doing it, and I'm happy to hear that it's happening among Catholics as well. A point about history, though, and how it relates to COVID. All of that, HIV activism that we saw in the 80s and 90s brought us to the point where we had emergency use authorizations for vaccines and treatments for COVID. And that's like when we talk about history, we should also be talking about the successes, because all of us everyone in this room, we're all vaccinated. And had it not been for the HIV activists working so many decades ago to break the gridlock in medication approval processes and research processes, we would all be walking around still terrified of COVID in the same way that people were terrified of HIV back in the 80s. So we should also tout our successes when we talk about the history of how HIV has evolved over these 40 years.
Oh, no, absolutely.
Fantastic.
That's what I was going to say.
I'm sorry.
It's
I know
fine.
your point.
But I do think one of the ways that the history matters is because I hear from young people all the time, it's no big, HIV is no big deal, it's one pill a day. And I'm like, do you have any idea what it took for you to get to one pill a day? I was on the first AZT studies. I was on the first studies of Crixivan, liquid Crixivan. So, I think that it's important that they know without it being badgered with it. It's a delicate balance between saying you should know, but at the same time being grateful for the progress that we've made. That we have U equals U, which is such an important and the only 100% protection from transmitting HIV. And I wanted to thank you for bringing up trauma, because I started an organization a few years ago called Let's Kick Ass. The ASS stands for AIDS Survivor Syndrome, and it's all about the trauma. Because I went through 5 years of hell where I wanted to kill myself when I was confronted with the idea of, holy shit, I'm gonna be an old man with AIDS. And it was something that was really hard to wrap my brain around, and it scared the hell out of me. But I'm on the other side of it now, and I'm much stronger for it. So thank you for bringing up trauma, because I think we could all be aware of the trauma that everybody brings into the past. Once you hear that test result, you're positive, that's trauma. Thank you very much. This is a wonderful session.
Carol, are you coming to the mic?
I am.
Okay.
You know I am.
Yes.
I want to ask the panelists about membership in professional organizations like ANAC. How do we engage newer, not necessarily younger, but newer nurses and other members of the healthcare team in understanding what a professional organization brings to them? And it certainly is maybe a little different than what brought people together in the 80s, but what are some of the facets around the work that we do now that might bring new members into the organization?
So, as a BSN, I'm going to bring up academics. As you know, that's a long-standing discussion with ANAC. ANAC has a lot of highly educated nurses, and many of them sit in educational institutions. But nurses, the majority of nurses in the United States, are working on the front lines. So it's one thing to talk about this in academic settings and to educate those nurses about HIV, but what do you do with them when they leave the school and when they go out into the world, and how do you connect them? I think if when you're talking to people when they're in school, you get them connected to nursing organizations and they see the value of coming to conferences and reading nursing journals and things like that, it'll make a difference. But I mean, for many, many years, I mean, in the early years of ANAC, we had nurses that were working on units, and they were kind of a natural group of people, and they went to local chapter meetings and things like that. Now you've got nurses scattered in all kinds of roles all over, all kinds of outpatient roles, and often working in small settings. And how do we find those people, and how do we bring those people to an organization? I think there's a wealth of riches to being a part of ANAC, but we don't seem to connect with those people, and I think it's important to find that. I think I love all the academicians, and I think they're great, but we're missing a whole segment, and we need to get to those people.
That's what I was going to say. As an LVN, it is incredibly inspiring to be around all of these letters. But if I wasn't the person that I was, it could also be incredibly intimidating. And so it would behoove ANAC to reach out to more LVNs and LPNs and help them understand that they have value, and that if they do have aspirations and career goals and they want to get letters, that all of you are here to help mentor them. Like I did and I do. I've been telling people like for the last 2 days how happy I am to be here. And I just am, because it is very much like a family-like kind of environment, and it is, everyone says hi and everyone's encouraging. But like I said, if I wasn't who I was, I could be intimidated by all of these letters that are in here. You guys are an awesome group. So think about the little people.
You're not little.
Yeah, we
You're
don't have
not,
little
and I
people.
mean that. So I actually would like to put out that those of us who are in academia, we get supported to come and to maintain our connections, even when, you know, life gets busy and all of those things. I don't know that the supports that nurses on the units, nurses in the clinics, it's not there. And I see you're shaking your head, I know that.
Not there.
And that's the problem. Because if the funding's not there to get to a meeting, or, you know, to get to this big meeting, you're not gonna come, or you don't get the, you know, or you don't get the time off. You know, I was lucky that my boss actually said, "You're going," and just made sure that the money was there for me to come, and then I was hooked, you know. But that's what I see, that's the biggest
But then maybe
obstacle.
maybe part of the problem is our model. And not our ANAC's model, I mean, it's professional organizations in general. Part of the problem is the model. I mean, the model is set up for people who have grants that fund them to go to conferences and do presentations and pay for their journals and all that kind of stuff. So, and I think we've learned a lot in the last year and a half about another way to have meetings with people and another way to reach out to people. And, you
But-
know, there are ways to reach out to people, and there are ways to engage people.
But I'm just saying that, and again, just, we need the hospitals and the clinics to support people to come, and not necessarily funnel all that money to the people with the MD behind their name. Maybe some of the RN initials
Yep.
need to get some of that access to those funds too. So that's what I wanted to say.
All right, I'm going to move to you over here.
Yes. It's been a pleasure listening to you all on the panel and the information that you have shared, especially about going back in history of the epidemic and how important it is to know that, because we don't want that to happen in the end of our lifespans. Those of us living with HIV who can no longer live independently and will have to be housed in assisted living or nursing homes. We've learned from COVID that those places aren't prepared to care for anyone, let alone anyone that has HIV or needs specialized medications to continue to live. And so we have to be active at looking at changing policies, changing, in Maryland it's COMAR, I don't know what it is anywhere, but the regulations and the required curriculum and training, because I don't want 5B to be happening as we are aging with HIV.
Wow.
Yeah.
All right, we have time for one more question, and we have one person at the mic, so that's perfect.
I really just want to make a couple of comments. First, I want to say that personally, I've experienced that ANAC is working really hard to involve those of us that don't have letters behind our name. I'm a 3-year RN. I was recently elected to be a director at large on the board and able to participate, and I've had lots of support from all of the board around the importance of having frontline nurses represent. So I just want to give ANAC a hand for that. And then I also want to just say, we talked about the 1 pill once a day and how, you know, people say it's just 1 pill once a day, it's not all that big deal. And I think the people, the kids, the young people that say that or believe that don't understand the weight of the stigma that comes with it.
They don't.
They don't, all they think of is it's no big deal, but then when they get diagnosed, they have all this stuff that they didn't anticipate that they're gonna have to deal with. And I also have been saying for a long time, and I know it probably never will happen, but we need the community that is dealing with this infection, this virus right now, needs people to stand up for them and act up for them like we did in the 80s and 90s. There's no support for folks right now who are newly diagnosed in that way. And so I just, I applaud all of you. I want to talk with some of you after this about some of the struggles, but thank you very much.
To your point, there's this, and it's really sad, and I'm sure some of you have heard about it or felt it or seen it. There's this sense of fatality with young Black and brown men that they're just gonna get it. It's gonna happen eventually. And we have to do something to change that because they're not taking care of themselves in a way that would prevent them from getting it because they feel like they're gonna get it anyway. And so I think that needs to be part of the plan for how we're gonna deal with prevention. That needs to be a part of the prevention model.
Let's give our panelists a huge round of applause. Thank you very much. I've enjoyed being with you and talking with you. Carol?
Take it in, take it in, take it in. I know, take in some of the other words that have been spoken about us while we've been here. Integrity, magical, strong, resilient, present. So those are some of the words that I've heard. I want to thank you, all of you, for agreeing to do this and Yeah, thanks so much. And so I'm going to turn it over to Mel, your new president of ANAC. She's going to take it from here.
Thank you, Carol. Thank you. Thank you very much. And I do want to comment on what Bill said. I am a frontline nurse. I'm the new president of ANAC, and I am a frontline nurse. And I've been working since 1984 in HIV care, and I have been through the entire paradigm shift of HIV, and I continue to train and teach in HIV clinics all throughout the country. So I'm hoping that that tide is turning a little bit and we're shifting that. So thank you all. And I am so excited. The year has just begun. So I am so happy to announce that we are going to Tampa next year. Y'all coming? Yeah, I hope so. I do also, I have an ask for everyone. If you could commit to bringing one new person to conference next year, because that is a way that we can hopefully try to bring more members and more allies to ANAC, right? So I'm asking you all to do that, to commit to that, like Darcel has, and so many of you have each year. And it just really helps us look at the amazing people that now are in ANAC. So I have a couple of reminders before. Let's see, we have Tampa, Florida, save the date. Is the slide ready to go up? There it is. See you in Florida, November 17th through 19th. So I hope you're going to think about that. Ask for permission to get off right now. Mitchell also mentioned that one of the things that we need to think about is a carve out in the budget so we have more scholarships for LVNs and RNs that are working and are not allowed or can't afford to come, right? Don't have that continuing ed budget anymore. So that's an exciting thing for us to start working on as a board. So come to Tampa, please. Bring somebody new, colleague, ally, friend. A reminder that next is the beautiful celebration of life from 5:30 to 6:30 in Potomac 1. And the awards dinner, if you got a ticket for that, is 7 o'clock right here. So thank you all for your attention, and safe home, and see you soon. Thank you.